All right, let's begin. So welcome everyone, and thank you for joining us today for our presentation, COVID-19 Across a Lifespan. I want to thank our partner organization on this presentation, the National Hispanic Medical Association, for helping us put this together. Just a really quick housekeeping items before we begin. If we can move on to slide number 2. We are providing simultaneous interpretation into Spanish for this presentation. So we're going to quickly run through how to listen and view in the language of your preference. If you want to view the Spanish language slides, please go to the top of your screen where you will find a tab that says View Options. Click on the tab, a drop-down menu will appear, and you can select from there if you want to view the Spanish or English presentations. Likewise, at the bottom of your screen in the Zoom toolbar, there is a globe-shaped interpretation icon. Please click on that icon to select the language you want to listen in. Next slide, please, Dr. Diaz. This presentation has been approved for continuing medical and nursing education by the American Nurses Credentialing Centers Commission on Accreditation and the American Academy of Family Physicians. Nurses, physicians, and CHWs or promotoras can choose to receive a certificate when you complete the final session evaluation that we will share at the end of this presentation. Regardless of the certificate type that you would like to receive, submission of the evaluation is required. Next slide, please. Excuse me. And to comply with both ANCC and AAFP, I need to let you know that we have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose products or services are related to pertinent therapeutic areas. Next slide, please. And with that, I'm going to introduce our speaker for today, Dr. Chanel Diaz. Dr. Diaz is an assistant professor of medicine at Columbia University's Medical Center and the internal medicine medical director at the Charles Rangel Community Health Center. Excuse me, Dr. Diaz's work focuses on community engaged approaches to address immigrant health inequities resulting from immigration enforcement policies. As a resident, Dr. Diaz has joined a network of volunteer physicians visiting immigration prisons to evaluate detained immigrants with serious medical conditions to document unmet medical needs. Bearing witness to many harms detained immigrants experienced influenced her in pursuing research collaborations to document the health harms of immigration imprisonment and publishing several opinion pieces in the lay media on the public health hazard of immigration detention. Dr. Diaz has collaborated with other medical and legal experts to develop best practices in medical evaluation of individuals in immigration detention and has trained dozens of residents and medical students. Dr. Diaz is committed to using her voice as a physician advocate to uplift human rights, health justice, and equity. With that, I'd like to thank Dr. Diaz for being here today, and I will go ahead and turn it over to you. Dr. Diaz, please take it away.
Hi, everyone. It's such a pleasure to be here with you today. I've listened in on many webinars with the Migrant Clinicians Network, and so it's really exciting to get a chance to share the space with you today. These are some of our broad objectives for the discussion today, really focusing on best practices around prevention and care of COVID-19 with a special focus on underserved immigrant and migrant populations, covering some of the updated guidelines and really discussing the implications of COVID-19 for chronic disease management. To give you an outline of the talk, I'll actually start with some definitions so that we're on the same page in terms of language that we're using in this discussion, and then really give a background on the impact of COVID-19 on immigrant communities before I get into the best practices. And then the presentation will conclude with really thinking about immigration-informed COVID-19 care, and I'll really explain what I mean by that term when we get to that point. If at any time I am speaking too fast for interpretation, please someone just unmute and tell me to slow down because I won't be looking at the chat. I find that it's helpful to really reflect on our own positionality with topics when we're presenting. And so just to give some context in terms of what my background is, I was raised by my maternal grandparents who migrated to the US in their midlife. And so from a young age, I helped them navigate the US health system, both as their interpreter and advocate. I'm also a primary care trained physician, trained in social medicine, and I've always cared for largely immigrant communities. And I have a particular expertise in conducting forensic medical evaluations for asylum proceedings, as well as human rights advocacy. So I'm here to talk about how we can better meet the health needs of underserved immigrant and migrant communities when it comes to COVID-19. I want to ground our conversation today by defining terminology with an emphasis on using humanizing language. So the UN defines the term migrant as any person who lives temporarily or permanently in a country where he or she was not born and has acquired some significant social ties to the country. Migrant is the most neutral and accurate term we have to describe anyone who migrates, including refugees. A refugee is someone who's been forced to flee their country because of persecution, war, or violence. And an asylum seeker has left their country due to persecution, but has not yet legally been recognized as a refugee. Finally, an immigrant is someone who's already come to live permanently in a new country. And although undocumented immigrant is not ideal nomenclature, advocates use it, as well as non-citizen, for lack of better terms, to refer to individuals that are present specifically in the US without authorization. It's important to remember that regardless, ultimately people are neither defined by nor should they be reduced to their immigration status or associated traumas. So at the end of the day, we're really talking about people, and we have to bring that humanity into it. So before getting into current best practices in COVID-19, I want to spend some time discussing the disproportionate impact that the pandemic has had on immigrant and migrant communities. Those of us who care for immigrant and migrant communities know that immigration status is a critical but often overlooked social determinant of health that really drives health inequities. And this was really particularly relevant during the start of the COVID-19 pandemic. So we know that health depends on the quality of environments where people are born, where they grow up, live, work, and age. And these are the social determinants of health. Structural determinants include the governing processes, economic and social policies that affect pay, the working conditions, housing conditions, and educational access. These ultimately impact the quality of the social determinants of health experienced by people in their neighborhoods and communities. So immigration status should really be understood as both a social and structural determinant of health. A person's immigration status can influence their employment opportunities, their living conditions, and their access to care, just to name a few. It's an inescapable form of everyday inequality that leaves immigrant communities vulnerable to poor health outcomes. That being said, in the US context, it's really important to acknowledge that current US immigration policy is a manifestation of structural racism. It's rooted in a legacy of racist US immigration and criminal laws that date as far back as the Naturalization Act of 1790, which limited US citizenship to white persons. So from the start, US immigration policy has defined racial groups and, given the privileges that come with citizenship status, reinforced social hierarchies, and these have implications for health. The figure on the right illustrates how state-level policies shape immigrants' access to opportunities which promote health. For example, labor and employment policies can create social and economic security or insecurity. They can promote immigrants' certainty or uncertainty about their daily lives. And structural racism leads to health inequalities by creating disparities in risk, access to care, and quality of care. So just by focusing on disparities of risk, we'll take the pandemic as an example of how occupational exposures and social inequality led to increased risk. During the start of the COVID-19 pandemic, immigrants were simultaneously one of the most affected and least protected groups. Immigrants, particularly undocumented immigrants, face heightened risks of COVID-19 due to factors like living in crowded housing, working in essential jobs with high exposure risk, and lack of access to testing and treatment. Although making up just 17% of all U.S. workers, immigrants were overrepresented in jobs critical to the COVID-19 response. They made up 29% of physicians, 22% of nursing assistants, 39% of food processing workers, and 48% of general agriculture workers, all categories of essential workers. And despite the contribution and disproportionate economic burden faced by this group, millions of immigrants and mixed status families were excluded from stimulus packages that were designed to offset the economic losses during the start of the pandemic. This paper, entitled Citizenship Matters, demonstrated that non-citizen status was actually associated with higher COVID-19 mortality rates in cities with in New York City and Los Angeles. So after controlling for multiple factors, they found that communities with larger shares of non-citizens experienced higher COVID-19 mortality rates. And this is not surprising when we consider the systemic inequities and barriers that non-citizens face in accessing resources, and specifically health resources. It is important to note that the excessive deaths of Black and Latino people from COVID-19 revealed the inextricable connection between systemic racism and the health disparities that we measure. Going back to these the ways in which structural racism really leads to health inequities. Once infected with COVID-19, immigrants also face several barriers to accessing high quality care, including lack of linguistic and culturally concordant care, discrimination, underinsurance or lack of insurance, fear of deportation, and difficulty with navigating a very complex health system. Especially early in the pandemic, but still true today, many parts of the country, it's been much harder to access information about preventing COVID-19 or getting tested for those whose primary language is not English. Non-citizen immigrants are also 3 to 4 times more likely than citizens to be uninsured and to face barriers to enrolling in health coverage even when eligible. Non-citizen immigrants are less likely to have a usual source of care. So for example, about 38% of undocumented immigrants report no usual source of care other than the emergency room, and that compares to just 12% of citizens. And in recent years, immigrant communities have faced relentless attacks by politicians. Fear of immigration enforcement and deportation deterred many immigrants from seeking medical care, even when severely ill with COVID-19. Policies like the public charge rule, which was implemented essentially at the same time as COVID-19 hit, penalized immigrants for using public benefits like Medicaid and food assistance, further discouraging them from accessing critical health care and preventive care. And these policies have really exacerbated the vulnerability to COVID-19, and the effects of this really persist to this day, and has really just undermined other public health efforts to control the pandemic spread.
Dr.
The
Diaz,
federal,
just a really quick message from the interpreters, just slow down just a little bit.
Slow down? Okay.
Just a bit, yes, thank you so much.
So federal policies have both facilitated and actually hindered access to care in the context of COVID-19. And so at the start of the pandemic, federal agencies actually expanded access to COVID-19 testing and treatment for uninsured populations. regardless of immigration status. Some states also approved emergency Medicaid to cover COVID-19 testing and treatment services. But some of these programs were opt-in, and some states did not really expand coverage. So concerns around the cost of care remained. And we also know that concerns around immigration-related fears remained because at this time there was no ban on immigration enforcement activities in medical facilities. I wanted to bring this to the front because while we were already facing significant barriers, we're now undergoing the unwinding of the Medicaid continuous enrollment provision that was established during the public health emergency. And so this means that many immigrants that are enrolled in Medicaid may be getting kicked off of Medicaid and face barriers to re-enrolling due to language barriers or just lack of information or confusion around eligibility rules. So I really want to flag this for all of us as an added challenge that will continue to impact people's access to care. So we're going to switch gears slightly to talk about current best practices in COVID-19 treatment and prevention. I just want to pause to see if there are any questions that I should address at this time.
I haven't seen any questions come in, so I think we're good for now. Thank you, Doctor.
Great. All right, so I'm going to talk about what we have in our arsenal at this time in terms of COVID-19 prevention and treatment, and hopefully address some of the questions that may be arising with changing recommendations. But just to kind of remind everyone, we have vaccines, we still have masks, testing, isolation, treatment. These are all really key to the prevention of COVID-19. So COVID-19 vaccination actually reduces the risk of symptomatic disease and hospitalization by at least 50%. And what we know is that over 95% of adults that were hospitalized in the last year due to COVID-19 had no record of receiving the most up-to-date vaccine. So it's really a critical intervention to prevent the severest forms of COVID-19 and to prevent hospitalization. Just as a reminder, all individuals age 6 months and older are eligible for the COVID-19 vaccine and is covered by most insurers, and there are different federal and state programs to also cover the cost of vaccines for uninsured individuals. Everyone who's 5 and older should get at least 1 dose of the updated COVID-19 vaccine. And the vaccine was most recently updated in the fall of 2023. So the recommendations are slightly different if somebody has never been vaccinated before compared to if they have been vaccinated before. So for anyone who's never been vaccinated before, they're considered up to date if they have at least 1 dose of the updated Pfizer or Moderna vaccine, or 2 doses of the updated Novavax vaccine. If they have been vaccinated before, they still need at least 1 dose of the updated Pfizer or Moderna vaccine, and it should be given about 2 months from the last dose. I want to add that immunocompromised adults may actually require an additional booster, and there's really great information on the CDC website about vaccines for immunocompromised and what the recommendation is in terms of booster vaccines for those who are immunocompromised. But just know that they may actually require additional vaccines. The recommendations for children are really based on age, And so I broke it down between ages 6 months and 4 years, 5 to 11 years, and those that are 12 years and over. Um, so I'm not going to go through each category, but just to know that it does depend on the age and that this is really to complete the series, right? At this time, boosters are only being recommended for kids 5 and older. A common question that I get is, I just had COVID-19. When is it okay for me to get the vaccine? So someone can get the vaccine as soon as 10 days after being vaccinated with COVID-19 if they feel well. However, you can delay getting the vaccine by up to 3 months after an infection because the chances of getting reinfected during the first 3 months are much lower. That being said, I counsel patients that anyone who has a personal risk of severe infection, severe COVID-19 disease, or has high-risk loved ones in the house may not want to wait the full 3 months, depending on what the transmission is like in the community. Most communities right now are seeing decreased rates of COVID-19 transmission at this time. They were peaking in about December, January. So it's really important to follow what the trends are in your community to know when is the best time to really get that updated COVID-19 vaccine. And I guess one last point to this is that COVID-19 is a type of virus that even though you may have gotten it once, you can get it numerous times again. So infection itself doesn't prevent someone from getting reinfected in the future. And that's why vaccines are even more important in the setting of COVID-19. We also know that masking is extremely effective at preventing the transmission of COVID-19. So I like this graphic because it really kind of gets at the difference between the masks. But what we know is that even cloth masks offer some protection. The most protection comes from respirators such as N95 and KN95 masks. And surgical masks are also very effective at preventing the spread of COVID-19. So what researchers have found is that universal masking and ventilation prevented most COVID-19 transmissions in the hospital setting. And so this came from a study that was recently published in January in Clinical Infectious Diseases, and they basically used genetic testing, electronic medical record information, and contact tracing to really map out how COVID-19 spread in the hospital and what were the most effective interventions at preventing the spread. And really having adequate ventilation, which included 5 clean air changes per hour, combined with universal masking, were the 2 interventions that prevented most transmissions. In patients who are known to have COVID-19, the use of personal protective equipment, especially by healthcare workers, virtually eliminated any healthcare associated transmission. So what we know is that testing patients in the hospital to really identify who may be asymptomatic but infected with COVID-19 and quickly isolating them, using personal protective equipment, especially masking, and having adequate ventilation are really essential to preventing the spread of COVID-19 in our facilities. And when we look at testing, we really have 2 main options when it comes to COVID-19. We have the PCR test and we have the rapid antigen test. So the PCR test actually detects genetic material from the SARS-CoV-2 virus, and it's considered the gold standard the most accurate way of detecting COVID-19. The sensitivity is almost 100%. The downside is that it can take 1 to 3 days to really process and get results because it does require laboratory processing. The upside is that it can detect the virus even before symptoms start. In the community, we tend to be using more rapid antigen tests, and these are looking for proteins on the surface of the virus. They're not as good at detecting the virus as a PCR test, and they tend to be most accurate when people are most infectious, meaning when their symptoms first start and the virus really peaks, which can take a few days. The positives to the rapid test is that we can get results within 15 to 30 minutes. And so they're, really easy to use in the clinic and community setting. The key is really repeating tests. So I'm going to get into that. So when someone is first exposed to COVID-19, there can be an incubation period, which can last from hours to days. And then the initial symptoms and really peak of the virus start. When there's a peak, that's the best time for the rapid test to be most accurate. So generally what we recommend is that if somebody has symptoms, that they should do a test, and even if it's negative, they should repeat that test in 1 to 2 days. So at least 48 hours to really exclude COVID-19. If somebody was exposed to COVID-19 and is high risk, maybe hasn't had symptoms yet, they should test about 2 days apart at least 3 times before they can say that they really didn't contract COVID-19. We have treatments available, and what we know is that the treatments are currently underutilized, and some of our highest risk patients are not getting the treatment for COVID-19. So there's really good evidence that antiviral treatment for people with mild to moderate symptoms who are at risk of severe symptoms reduces their chances of ending up in the hospital and reduces their chances of dying from COVID-19. So Paxlovid and molnupiravir are both available as pills. They're available by prescription. Remdesivir is still an infusion that usually requires being in a healthcare setting to receive. The preferred agents are Paxlovid and remdesivir right now, but because Paxlovid has a lot of drug interactions, some patients may need to actually get molnupiravir instead if they have medications that interact with Paxlovid. The medications are most effective if they're taken within 5 days of the start of symptoms. And that tends to be the challenge, is really, a patient getting connected with a healthcare provider within 5 days and really getting that diagnosis in time to be started on treatment. But we do know that medication can decrease the risk of hospitalization by 75% and risk of death by 60%. So it's really critical. The treatment is really, it is available for children, but ages 12 to 17, and really just for the highest risk children at this time. And so this is probably really hard to read, but it goes into how we assess who could benefit the most from treatment. So certainly thinking about anyone who's over 65, whose immune system is weak, who has a lot of medical problems, as long as they're within those 5 days of the symptoms starting, they are eligible for medication treatment. Now, there's been a lot of discussion recently on changes that were made to the isolation guidelines provided by the CDC early this year. So the isolation guidelines have been brought in to just include respiratory viruses in general because, you know, it's getting more challenging to really understand if somebody has COVID or flu, because some of the challenges that I described with the rapid test, having to test multiple times. So they've brought in their recommendations to really just cover respiratory viral infections. And so they're no longer requiring 5 days of isolation after a positive COVID test. What they recommend is isolating until symptoms are improving and the person has no fever for at least 24 hours without medication like Tylenol or ibuprofen that treats the fever. And the recommendation is to wear a mask when individuals who with COVID infection are around anyone else to prevent the transmission for 5 days after testing positive. And so in terms of who do we consider to be high risk? The list is actually very long, as you can see. So on the left, it covers highest risk children, and these are those children who have asthma, cystic fibrosis, chronic lung conditions, children with seizures or other neurologic conditions, children with heart disease, who are premature, as well as children who have other conditions that make their immune system weak, or who have obesity and diabetes. For adults, the list is longer for conditions that really make someone at higher risk of being hospitalized or even dying from COVID-19 if they contract COVID-19. And so we know that anyone who has lung problems, who has heart problems, heart disease, kidney disease, liver disease, diabetes, cancer, whose immune system is weak because they've gotten a transplant or they're on steroid treatment, anyone with dementia, smoking history, mental illness, and obesity are considered high risk. And I will say that pregnancy is also considered a high risk condition. But even outside of any of these conditions, anyone who's unvaccinated, who's never been vaccinated, is at really high risk of severe COVID-19 infection, especially if they have not had COVID-19 before. So that's where I'm seeing some of the sickest patients in the hospital is among people who are unvaccinated. So now I want to end by discussing what immigration-informed care looks like for COVID-19. And so healthcare centers can really play an important role in addressing some of the harms related to immigration policies by adopting immigration-informed care. And this is a concept that was proposed by Dr. Altaf Sabi and colleagues in California that really builds on trauma-informed care. And trauma-informed services encompass the principles of safety, trustworthiness, transparency, peer support and empowerment, cultural competency and humility across all services. in addition to the core principles of trauma-informed care that are relevant for this highly trauma-exposed population, components of immigration-informed care include appropriate language services, clearly delineated referral pathways, especially for undocumented patients, culturally and structurally competent clinicians that are trained to discuss sensitive topics without inciting fear, institutional policies that ensure the physical and psychological safety of immigrant patients. This includes avoiding documentation of immigration status in the medical records and limiting cooperation with ICE, and establishment of medical legal partnerships to address immigration status as an important determinant of health. So I'd like to think about immigration-informed care and how we really deliver our messages around COVID-19 and how we continue to treat COVID-19. And so I think it's especially important because we know that the intention to be vaccinated is higher in immigrant families, but the uptake is lower. So we still see significant disparities in vaccination rates in immigrant communities. And it's not surprising because there are so many barriers to getting vaccinated to this day. I like the figure on the left because it outlines the journey that one has to really take to get a vaccine. It details the factors that can influence somebody's decision making around vaccines, like their social influences, understanding of the facts, religious beliefs, cultural values. But it also outlines all the steps that somebody has to take, like taking time off from work, ensuring childcare, figuring out how to access a clinic, and then the trustworthiness of that clinic. All these considerations that somebody has to take when making that decision. And so we still face the same barriers that I had outlined before around immigration-related concerns. And so it's really important when we think about vaccine outreach around patient education to really address the concerns related to confidentiality, concerns related to, providing information about people's home addresses or disclosing health conditions. And so as much as we can, avoid collecting and asking for personal data for our public vaccine campaigns, and as much as our outreach efforts can involve trusted community organizations, community health workers, and can really speak to the immigration concerns that people have, that's what's going to start to address these disparities that we see. So there is actually a review article that outlines some strategies that can be adopted to promote equity in COVID-19 vaccination uptake for immigrant communities. And some of the strategies that they highlighted is really having multilingual outreach and education campaigns that are led by trusted community leaders and organizations, the importance of free and accessible vaccine clinics with flexible hours and locations, the importance of confidentiality and just asking as few questions as possible, right? Collecting as little information as possible to address those immigration related fears, and really leveraging the power of community health workers and mobile vaccination units to reach some of our more structurally marginalized populations. Still on the Department of Homeland Security website, it still does say that, people should be able to access COVID-19 vaccines, regardless of their immigration status. And so that's still the messaging from the federal government. But, it takes work on the ground to make that a reality. And so I want to highlight different resources that I think have, just done an incredible job in messaging to communities. And so the National Center for Farm Worker Health has COVID-19 educational materials. And so the website's here at the bottom, and these are examples of some of the handouts and flyers that they have.
Really quick, Dr. Diaz, we did have a question that came in, if you don't mind.
Sure.
This question came in, just hold on 1 second, you can pull it up here. What is the current variant? And I guess it's 2 questions. What is the current variant? And will the new vaccine that came out be an annual vaccine?
I think that's a great question in terms of the annual vaccine. So far, that hasn't been the official recommendation, but I wouldn't be surprised if we do. We're still seeing Omicron variants, and what we do know is that the most up-to-date vaccines have really good coverage for Omicron variants. But as the virus spreads and evolves, there will be new variants, and so there may be need for continually updated vaccines. We don't really know if that is going to be the recommendation moving forward. What studies have found is that for most people, the protection really drops significantly 6 months after receiving a vaccine. And so that's where a lot of experts have been, recommending continuing with boosters, because that protection does really seem to drop even 6 months after getting a vaccine.
Thank you, doctor. And the next one isn't so much a question, more as a statement that was, one of our attendees wrote in that a lot of people talk about the side effects of the vaccine and therefore they don't want to get vaccinated. I wonder if you could speak a little bit to that.
Yeah, I think it's really important to, when having conversations with patients, to really understand what their concerns are. For some, it could be the side effects. So I've had some patients that's like, I don't want to get it today because I have to go to work. I would rather come a different day, right? So is it a matter of not, wanting to delay it, or is it a matter of being so concerned of the side effects that they may not want vaccinations, period? And that's where I think it's really important to understand what those concerns are, and if it, if it's grounded in facts and in the information that we have, or is it, some misinformation around the concerns around vaccines.
Thank you, doctor. And that really is an important point, that you need to really talk to your patient and understand where these fears are coming from, and, try to get on the same page. So thank you.
Yeah, and I just also want to highlight another great resource around COVID-19 education that's for patients and communities, and that's the Migrant Clinicians Network's COVID Resource Hub. And I think what's wonderful is I actually think that their frequently asked questions are really helpful, get at a lot of the frequently asked questions. And so if you're looking for, how, like, language around how to answer some questions for patients, I think that's a great place to go to, as well as for, handouts and posters to have at clinic and
I
share with patients.
I can speak a little bit to this as well. Our COVID hub has resources that support health centers, health departments, community organizations, and clinicians, specifically those that work with the migrant immigrant communities. So do check out the hub. There's a ton of information on there you can download and access easily. Thank you.
Yeah, and this is more, in terms of the frequently asked questions, which can all be found in the hub.
Yes, and just quickly speaking about the
Sorry.
FAQ. No worries. So this is 4 years into the pandemic, and we still get a lot of questions from our clinical network around a multitude of COVID-19 related topics. So our FAQ offers the newest questions, followed by an archive of previous questions. So do check those out as well. There's a lot of information there also. Thank you.
Oh, oops, I jumped ahead. And I do want to also acknowledge that we need a diverse and like culturally concordant healthcare workforce. Just within the context of Latina immigrants, we know that Latina individuals make up 19% of the U.S. population, but only 7% of physicians. And I feel like I can speak from that at a personal level, just the importance, like what it means to be able to connect with patients in the language with which they're most comfortable, what it means for them to see their culture represented and just understood in a different way. Like I easily understand the power of that, but I think that it's really important to also think about representation within like our healthcare workforce. And I want to I'm going to circle back to this, but I also just wanted to put out there that these are different resources, and I will drop the links in the chat. And the treatments.hhs.gov in particular do have resources for where individuals can access treatment, including if they're uninsured. And so there are different patient access programs, like through Paxlovid, through the companies that also ensure access to these treatments for individuals who don't have insurance and can't otherwise access it. So I'll drop these links in the chat. But I'll also share this slide for other ways to connect with the Migrant Clinicians.
Yes, so of course you can follow MCN on our various social media platforms. You can access resources, get updates from the field, and you can hop on a Zoom webinar as we're doing right now. Thank you, Doctor.
Yeah, and so I think we have time for questions now.
We do have time for questions. So one comment did come in. Someone put in there that I've even heard doctors on the Latin news outlet claim that vaccines have side effects. So I don't know if you want to speak to that. So feel free.
Yeah, so there's no denying that vaccines have side effects. All vaccines have side effects, right? And some of them can be pretty serious. And so with any treatment, it's really balancing the risks with the benefits. And so that's why I think it's so important to think about the individual patient. Like, what is their work environment? Like, what kind of exposure risk do they have to COVID-19? What kind of chronic conditions do they have that put them at higher risk of severe COVID-19? Who's in their house? Like, are there high-risk individuals that live with them that they're trying to protect, right? And I will say that there's also a lot of misinformation around potential risks, right? And some of it is coming from physicians on social media and in the news. And so, I think that there's no denying that that trust has decreased. Like trust of the CDC, trust of like official organizations. And so that's where I think that the one-on-one relationships and establishing trust with providers is so key to really addressing patients' concerns.
Yeah, great. Thank you, doctor. A question just came in. What are good ways to encourage children to be vaccinated if parents aren't in minority immigrant populations? So I think that's just a good question. Just how do you just encourage children's parents to get them vaccinated in general, right?
Yeah, absolutely. I think that there, so so luckily, what we've seen is that you know, children have lower risks of severe COVID-19, both of getting hospitalized and of severe consequences. Um, but, you know, they're in settings like schools where they can have a lot of exposure to COVID-19. And part of the, I think one of the reasons for getting vaccinated that I personally find most compelling is concerns around, you know, the long COVID or the long-term consequences of COVID. That a really high number of people experience symptoms months and even years after their initial infection. And so there's still a lot of research happening in that field to really understand, you know, who's at most risk. But, you know, I think that that's one thing that I find compelling, even in terms of, you know, counseling families and considering vaccination for kids, is that we are still only starting to understand the long-term effects of having COVID-19 infection. And what we know is that it's really safe in kids. The vaccine is really safe. We've seen very few serious side effects with kids. And so, you know, again, it goes back to that benefit, like balancing the risks and benefits for that individual family, and educating and making sure that we have, you know, like frequently asked questions and resources that we can share with them so they can read up more. So as much as we can provide people with those resources for where they can find information that's reliable, I think that's key.
I think it's important for organizations such as MCN and of course, you know, clinicians as well to really educate our populations so that these concerns can be met with correct information, right?
Yeah.
All right. If there are, I don't see any other questions coming in. So with that, I'm just gonna give you guys a few closing statements here. Just a reminder to please submit the evaluation, especially if you want to receive your certificate of continuing education. As I mentioned earlier, we cannot send you that certificate unless you submit the evaluation. I'm going to send a follow-up email later today with the links to the recording and the evaluation, including a PDF of the presentation. That PDF, the presentation, I'm going to send to you the English and Spanish versions, and all the links in the PDFs are active. So every link that you saw in this presentation right now will be included in the PDF and the link will be active. Let me see. And I don't see any other questions. I don't know if anyone else on staff has a question. Yeah, go ahead, doctor.
I see a question about, you know, the requirements around school and COVID-19 vaccines. And I think that probably is different in different states and counties in terms of whether they require COVID-19 vaccination for enrolling in school. I'm not actually sure. I think that might vary.
So, yeah, I feel like that's something that you would have to check your school district with your school district to see what those requirements are. Any other questions? All right, with that, we're going to end a few minutes early, but that's okay. Dr. Diaz, I want to thank you for being here today with us. And I'd also like to thank our interpreters for their wonderful work here. And like I said, I will be sending a follow-up email later today. If you have any other questions that you want to answer that you think of later on today, send them to me and I'll make sure that Dr. Diaz gets them and we will provide you answers to those. But for now, thank you, everyone. Thank you, Dr. Diaz. Thank you to the interpreters.
Thank you.
Everyone have a wonderful rest of your day, and you will be hearing from me later today. Thank you all.
Thank you.
Goodbye.
Bye.